everyone. This is David Bronstein from MCOL, and I'd like to welcome you all to our webinar event today, Transparent Cost Networks, a Consumer-Driven Solution. Our seminar speaker today is Will Fox, Principal and Consulting Actuary at Milliman.
Good morning, everybody, or afternoon, depending on where you're at. Thanks for joining us. I'm excited to talk about transparent cost networks. It's something that's bothered me for a long time. For most of you out there, I think, who have been around healthcare, we've had runaway costs consuming a bigger and bigger part of our economy. And just if you study economics and Adam Smith or Milton Friedman or anybody, the simple normal parts of economics just really aren't in healthcare. And so one of the things that Transparent Cost Networks is trying to address is getting the consumers more engaged, getting people shopping for the services, understanding what they're buying in advance, and making sure they're getting value, and then driving that value from the suppliers. So if we see here, David, I think I've got it working now. One huge thing that happens in healthcare that doesn't really happen in most other economic environments is that consumers aren't able to spend their money wisely if they don't have the information to make those cost-effective choices. So in our current model right now, people go in and get care in the hospital or physician setting, and they're able to, and then 3 weeks later you get a bill and find out what you bought and how much it was, and that's again not conducive to driving economic value. There's also no price pressure on the providers. If the purchasers aren't shopping for the services in advance, looking at what costs more, what costs less, they can't put pressure on those hospitals. Every hospital or physician has every incentive to drive their price as high as possible because nobody knows that their price is high. And so it's really based more on their negotiating leverage than the value they're providing to the consumer. And I think that's really creating this need for the transparent cost networks. And those needs are really coming also from one thing that's happened that's created this variation in pricing is the confidentiality provisions and contracts. Right now, a lot of the contracts between the payers and the providers, between the insurance companies and the physicians and hospitals, they're made to be confidential so that nobody else can see the contracts or understand them. And if you have been around, I do a lot of contracting analytics and work with the contracts and negotiations. And in there, it's easy to see and understand why this confidentiality has come up because essentially the largest payers have the best market share, usually have the best contracts, and they don't want anyone else to know what their contracts are because their competitors may be able to put pressure on the providers to give them the same deal. And usually the payers who are not in the best position, don't have as good a contracts, don't want everyone to know that their contracts aren't as good. From the provider standpoint, most of the more powerful hospitals and physician groups who have negotiated the higher rates don't want everyone to know they're more expensive. So all the incentives are aligned for people to keep that confidential, those contract information, except for really the employers and the consumers are the ones that really want that information. So I think this will take a pretty big change in changing things. And then the complicated contracting practice is another real problem for even if you wanted to, if you got past the confidentiality and we wanted to share the information, right now a lot of the contracts are so complicated it's really hard for a consumer to compare services across different hospitals or physician groups because you might have per diems in one arrangement and case rates or DRGs or carve-outs for high-cost new technologies, outlier provisions, and things that make it very difficult for an insurance company to say, hey, here, for that service, here's what it'll cost across these different providers. So transparent cost networks, I hope, will help with that. So moving on. So what is the Transparent Cost Network? So it makes that cost information available to members by provider and procedure, getting specificity for what they're going to get done, and shows what that member's resulting cost sharing is going to be. So this will allow those members to make good decisions about their health care and compare the providers in advance to see what it's going to cost. Now, I'm focusing here just on the cost piece, but a lot of this, it certainly will coordinate well with what's already happening. We're getting better and better information on quality and patient satisfaction, but cost is still a pretty huge component, and that part has been lacking. I think the other piece that people haven't spent a lot of time on is efficiency. And to understand efficiency, a lot of times you need to tease out what the unit price differences are among providers so you can get to that efficiency. So transparent cost networks, I think, will help us better understand efficiency, put the quality and satisfaction into context. I'm not saying get rid of those things, but it's also, and I'm going to talk about this more, will help us get to ACOs, patient-centered medical homes, bundled payments. All those things are going to work a lot better with this transparent cost network. So when people have this information, they'll be able to make better choices. So let's do a little quick demo of, so here's an illustration of what that cost comparison would look like. So a member comes in and says, okay, my physician says I need to get a colonoscopy. What's that going to cost? And so looking at this here, you can see that if the patient were to get that service done in the office setting, and this is based on real data, the physician would get $391. There'd be no facility fee, and the total would be $391. And the patient, if they're paying 20% of that, 1/5, they'd pay $78. Now, if that same physician, takes that service out to an ambulatory surgery center, then the professional fee goes down to $216. The facility fee goes up to $406, and the insurance company total cost is $623. Of that, 20% is $124. So at this point, that's $46 more for the patient. And I think it's helpful for people to understand this doesn't even require changing your benefit designs or doing anything, but making people more aware that changing location of what you're getting done has a big impact on your pocket. And I've heard too many people say, oh, people don't care, they won't take the time to research this. Well, if we make it easy for them and they understand that there's a $46 difference, we've put a lot of belief in, copays, driving behavior, and even a $20 copay, seeing that driving changes in where they're going. So I really think if we get this information in the hands of the members, they will change their behaviors. And you can see here going down, so if we said the two ambulatory surgery centers both are contracted at the same rate, so there's no difference, but there's 5 hospitals that are within some, you could type in a 5-mile or 10-mile radius. And we can see the variation among hospitals is really a very huge issue. And at the end of the presentation, we're going to send you a link to the white paper we wrote on the transparent cost networks. And one of the things it has in there is also some references of provider variation and transparency summaries that have been done elsewhere. So you might want to look at that. But the variation among hospitals in particular has been pretty well documented. And you can see here, again, this is based on some real data that if we say the physician part is not going to change as we go to these different hospitals, still going to be at the $216.97, but the hospital prices really increase pretty significantly, so that by the time you get to hospital E, this total cost for the insurance company and patient together is $1,546, over $1,000 more than if that same procedure, this is the same colonoscopy procedure, could be done in an office setting. And then the patient would be paying $309 instead of the $78, so over $200 more. And like I say, I really believe that if this information is out there, that it will change the consumer's behavior. It will put more price pressure on the providers, and could really bend the cost curve. Everybody's talking about bending the cost curve, and how can we do that? How do we align the incentives? Well, part of aligning the incentives is making people good consumers. And I think one of the things with our current model of the confidentiality and the complicated contracts, it's really hard to do. So the next thing I want to show out here is how to build this transparent cost network. So David, can you scroll it to the slide titled RFP-Based Transparent Cost Network? Seems to be not moving now.
Yep, we're there now.
Okay. So in building that transparent cost network, so one of the things that happens right now, a lot of the payers have a different contract for their HMO network, for their PPO network, and more creating a high-performance network. And so or a narrow network, and so they're creating different networks. And what we're talking about here is creating a new network, this transparent cost network, which would get rid of all the confidentiality provisions in the contracts, make sure everybody knows their publicly available information. And given that there's so much variation in the current contracts, it's like start them from scratch and build them all together at one time. I'll talk through that. If you tried to do every hospital and physician group one at a time, it would take forever to get it done. But if you did an RFP-based approach, you could do this in a single effort with a pretty quick timeline to then build a base fee schedule that accounts for the patient severity variation across the services, so that having a multiple of that base schedule will be comparable for an academic teaching center to a community hospital and across different physician specialty types. And then to build that base schedule, there's a couple easy ways. We can use Medicare as the base schedule, so it's easy to update, easy for the providers to understand. The other alternative would be, Milliman has RBRVS for hospitals and Global RVU's product, and we've built similar schedules. But using Medicare oftentimes is better for the providers to really understand that and be able to source back and update things over time. But one important thing is not to leave all the Medicare schedules as a bunch of different things, but to bring them all together so that there's a big long list, so by HCPCS, and you just have the values across each service. And I'm going to show that on the next slide. But the last thing is that when we build that schedule and then we negotiate that multiple, we want to also make it so that we're not negotiating every year and things being complicated in terms of updating what's happening. So indexed increases and revenue-neutral base schedule updates. So talk about those real quickly. That best practice contracts have set inflator factors using a PPI or a Medicare market basket or a CPI. Some ways to create that, index it so that we're not negotiating every year, and then also making it so that you do a revenue-neutral base fee schedule update. So every year, the Medicare schedules update, HCPCS change, and relative weights change. Over the last few years, like imaging services, the relative values have gone down, and we want to keep it fresh. But we also don't want that to get to confusing the negotiations, because oftentimes changing out the fee schedule really bogs down the negotiation. If you have a revenue-neutral provision where you can switch out the schedule on January 1st of each year and just give them the revenue-neutral change, let's say the fee schedule went up by 5%, or the base schedule of Medicare went up 5%, and you were paying them 125% of the base, revenue-neutral might be 120% times the new base getting there. So you can do it so it's pretty easy updates, and so then here's a quick illustration of what that base fee schedule looks like. Again, bringing together all those different fee schedules, the RBRVS, LAB, DME, ASP, ASC, ATCs, bring them all together into one place so that we have, for physicians, for the professional services, what's done in an office setting versus what's done in a facility setting. So there's two different prices there. And then for facility services, what's done in an ASC and a hospital setting. And so with this base, then every provider just negotiates a single number, a multiple of that base, for the services they deliver. Now, the only thing we're missing here is inpatient, which we'd have a DRG schedule there. So we'd have the inpatient DRG schedule, and then this, which covers all the professional facility services.
That concludes our event. Thank you to Will and all of our participants today.